spending your time with me today. And I hope, the benefit that you'll get from the small session of what COPD is, which will be super, super like overview, but also looking at the changes of where respiratory management is taking us. As you know, our Southwest London guidelines are up for review. They're going back to the IMOC. They're going back to formularies to find out what the pathway should look like and where should we be looking at how we escalate our therapeutics based on presentation. So with that in mind, and with what will happen in shortly in the future, I would like to give you a glimpse of what my thoughts are and how we can prepare ourselves going forward. And hopefully you should start seeing my slides.
They are there. So can I just check with you, Darshan, quickly? Would you prefer questions at the end, or would you like them relevant to slides as we go along? What would you prefer?
I'll bring them on, like this is the session for our colleagues. So I want it for them to be as interactive as possible. If you want to watch Coronation Street, then you sit back and watch Coronation Street. But today will be about COPD. So I want you to engage because this is your session. So please, and Chani, please, just let me know if someone are asking a question because I won't be able to see the function.
No problem.
Then
I'll keep an eye on it all for you. And then if there's any hands up as well, I'll give you a shout and say, Darshan, we've got a quick question, just so that you're aware. So I'll turn my camera off. If you see it come on, you know that there's a question or query coming through.
I won't see your camera, but just disturb me. Don't worry.
I'll just talk. That's fine.
Yeah,
I'll just talk.
you can see my slide.
We can indeed.
Yeah. So I guess we'll take a bit of a deep dive of what good management looks like and how we can actually help our patients going forward. Now, if for those guys who are not aware of what I do, I'm also your CPP rep for London, and I also work as a PCN pharmacist for Morden PCN, as well as my own pharmacy in Lewisham, Southeast London, and overall, like Chani, keen educator. And yeah, education is really the bread and butter for what we do, and it's really what gets us up in the morning because we can impart something on the next generation of our colleagues coming through. And today I'm going to discuss you about the impact of COPD from a clinician's perspective, but also, have you ever thought about what it means for your patients living day in, day out with the burden of COPD and the challenges that they are facing going forward? So with that in mind, I mean, we know with COPD, it's super common. It's the second most common prevalent lung disease after asthma, and it's estimated that 2% of the population has diagnosis of COPD, and this equates to approximately about 1.2 million people out there in England, okay, who are currently diagnosed. However, it's also been estimated that out there, also in our communities, day in, day out, there's an additional 2 to 3 million people still living with burden of COPD who are yet undiagnosed. And where that number has come from is really from smoking data, because they found that a certain proportion of people who are smokers, either short-term or long-term, tend to become having COPD diagnosis. So we get that from smoking data. So the so-called missing millions are the ones that we need to try to address. And COVID obviously hasn't helped. I mean, like, I know this is now talking about 4 years ago, but the impact of COVID is still impacting on our services today because we still have got a massive backlog. We've got people who have had a worsening outcomes on their current management because they've had to sit in their bubbles, stay at home, not go out unless they're going out for 1 hour or so. Otherwise, the police will tell them what you're doing outside, whatever. So what do people do? They sit at home, they vegetate, they eat rubbish, they smoke, they drink, they become fat, and ultimately it increases the burden of the comorbidities that already pre-exist, and on top of that, mental health is always impacted. So these individuals have been obviously left unchecked, undiagnosed, and also continue to live the life under the burden of COPD without actually being addressed. That's out there. So looking at the figures, we know that impact of COPD that we have currently, where almost 200,000 people who have got COPD with related emergencies over 21, 22 in England alone. So a massive burden, and of which 40% of patients with an exacerbation usually tend to be readmitted or tend to have high morbidity within 90 days of hospital discharge. Um, so, very stark figures, very doom and gloom. But I guess the lining is where we know over nearly 7,800 premature deaths could have been avoided. So this is where our teams really need to address that those individuals who are now diagnosed are also being managed optimally to reduce the burden of COPDs going forward, because ultimately it's someone's grandma, someone's granddad, brother, sister, make it personal. So I guess my learning outcomes for you today is, how can we identify factors to prevent the development of COPD? How can we see the signs of COPD? Like we see the signs of cancer, see the signs of COPD, okay, and address these signs early on to prevent the decline that suddenly occurs and to improve outcomes for these individuals. How do we navigate the guidelines that we've got currently to optimize from a pharmacological management point of view, but also from a non-pharmacological management? And how do we emphasize the benefit to the patients so that they can live the best lives, the remaining of their lives? So self-management and empowering patients is super, super important. I'm going to ask you a question, Chandni. Okay, come offline for a sec. Come online for a sec. Chandni, how many minutes do you speak to your patients in the course of a year? Say one patient who might have COPD, how many minutes would you speak to them? Miss
You don't
Chandni.
tend to see them very often, to be honest. So probably I'd say
Mm,
what, an hour maximum in the course of a year if they're coming back
yeah.
with exacerbations,
Mm.
infections, that kind of thing.
So you
I'd
might see them
say
at two
half
thirty
an hour
minutes
to
or
an
one,
hour. Half an
half
hour
an
to
hour
an
to
hour.
an hour.
Yeah.
Okay, so half an hour, 30 minutes to 60 minutes in a year. Okay,
Yeah.
another question for you, Chandni, before you go away. How many minutes are there in a year?
You're asking me a very interesting question on that front. Too many to count is what I'm going
Fine.
to say.
So there are
Thousands.
5,200, no, hold on, 520,000 minutes, 520,000 minutes in a year, and you only see your patient with COPD
The
for a better
60.
part of 60 minutes, okay?
Absolutely.
So what I want you to just at least take away from that point of view, if nothing else, the basis of power needs to be on the basis of the patient, because the
Absolutely.
patient is going to be living the rest of their lives with themselves and the families. So they need to know how to escalate the therapies and live well. We're only going to be, as clinicians, as GPs, pharmacists, nurses, whoever we are working in primary care, we're only going to see them for a minutiae of that time during the year. So we really need to empower our patients and educate them to make them give them the understanding of what to do next. So this is my
Absolutely.
point with all our long-term clinicians going forward. And we know with nice guidelines, with NG 115, we hope to address the fact that there is a massive impact of health inequalities in our community. And we know that the impact of COPD is significant in areas of depravity, okay, in areas where there's high unemployment, in areas where there might be overpopulation, poor schooling, might be the lack of green areas for people to enjoy or to have mindfulness and such. So the more built up, the more deprived, those areas, generally what we inverted commas call the poorer areas, tend to have a higher degree of burden with COPD compared to other individuals. And you look at your areas, guys, okay, look at your areas that you live in and work in, your PCNs and your GP practices. Look at the sort of demographics that you've got. And it's like within my PCN Morden, you can be expected to, if you were a patient at say Morden Hall Medical Center, you could be expected to live 10 years more compared to if you're a patient with my other surgery within my same PCN at Mitcham, uh, and this is all within the same neighborhood. So the area, the health inequalities, even within a neighborhood, within a PCN, is super differential. So we need to make sure that we try to harmonize that. And this fits really nicely with the fact that, yes, if you're poorer, you're more likely to smoke, you're more likely to develop COPD, you're more likely to have um, severe and a significant number of exacerbations. And as a result, you're more likely to die from your COPD. And this really plays nicely with the core 20+5, where there's a clear focus on that document with COPD to driving up the uptake of vaccinations, inoculations, but also provision of smoking cessation, and also to identify those missing millions, the utilization of spirometry and spirometry hubs within our environment. So we're really working at a back foot currently with our patients with COPD. Now, hopefully you guys have had some experience with COPD and you've been able to manage your patients coming going forward. But we know that COPD is a heterogeneous lung condition. It's usually characterized by the chronic respiratory symptoms of dyspnea, cough, sputum production, and exacerbations. And this is due to the abnormalities in the airways, so either like having a bronchitis and or having alveoli sort of damage, such as seen as in emphysema. And this basically causes persistent and often progressive airflow obstruction observed in patients who have that difficulty. And this is usually documented through objective testing via spirometry. And we know from the characteristics and factors from COPD, okay, we know it's progressive. We know there's no treatment for our patients. We can't magically cure our patients with COPD. There's no treatment. It's about pure management, okay? And this causes the individual to have difficulty in breathing. And we know the main causes tend, like we said, apart from smoking, is air pollution, the patient's genetics, but also other aspects such age. So you're more likely to have it after the age of 40, after a long exposure to say smoking, or potentially occupational exposure. How many times do your patients come in with a cough and they also work as a carpenter, or they might work as a bricklayer, or they might be exposed to certain fine dust, like for example in a bakery, or anywhere, or in a laundromat. So those individuals who work in that environment are more likely to be presenting to you with these sort of cough symptoms, sputum production, and generally increased risk of bronchitis. Individuals also may be exposed to secondhand smoke, especially if their family members who smoke within the home smoke within the parameter of that individual. And this is especially important for children growing up within that environment. You're also more predisposed to having COPD if you have childhood infections as well. So severe respiratory infections during childhood can cause lung damage and increase the risk of developing COPD in later life. And finally, those individuals with asthma, there's a higher degree of developing people with poor management of asthma. So effectively, the asthma has jump shipped and gone into COPD as a result of poor management with ICS, constant use of the blue inhaler, constant use of oral corticosteroids, causing that remodeling and fixed airway disease in poorly managed asthma, which then have the signs and symptoms of COPD, and as a result are managed accordingly. Now, we mentioned the genetics earlier, and that was pretty interesting because the alpha-1 antitrypsin deficiency, which is a genetic factor which can increase your risk of getting COPD because it doesn't keep your lungs as healthy. It causes aging of the lungs prematurely. And this is something which can be done through genetic testing. But in all honesty, it's not done in primary care. It's something that secondary care would tend to do. And this is the kind of like aspects that we would need to look at phenotyping from our patient's perspective, what they're likely to get later in life. And we know living with COPD from a patient's point of view, just think, if I asked you if you've got a straw and if you start breathing through a straw, you might be able to breathe through a straw quite nicely. But if I asked you, do a few on the spot running for 5 minutes and then breathe through a straw, you're not able to get enough oxygen to your lungs that meets the demand. So you'll be like having pursed lip breathing. And those individuals who are living with this terrible condition, avoidable condition, really, have very poor quality of life. And this is a depiction from ICB up north of what a patient's thought process would be. So it could be the fact that, they might be worried about going out. They might not be able to lift their legs. They might not be able to walk any certain distances. They always have to look for seats everywhere. They might be worried about uneven pavements because they can't support their legs. They might be looking at any inclines. So they always plan their route. Oh, I can't go this way because there's an incline and I get puffed out. I'd rather go downhill and go around, which might take a very longer route for that individual. But also from the patient's home as well. There's a fantastic document from Asthma and Lung UK about COPD management at home and things that exacerbate COPD, such as mold, such as dust. Um, Individuals who obviously might have animals at home. So same sort of things that we would do with with asthma. Same for the potential exacerbators and triggers that can worsen COPD control and cause an exacerbation. But apart from that, there's a lot of mental health issues with these individuals with COPD because they are not the same person that they used to be. And as a result, they might not want to go out. And a lot of my patients who, may have downsized from their semi-detached house to a bungalow, actually have done themselves a disservice because if you reduce your exposure to exercise, especially within your house where you're comfortable, then you're reducing your capacity of your lungs. It's almost like decommissioning or decompensating for your heart because you're reducing the stress that you're putting on your lungs. It always becomes easily decompensated. And I kind of use the synergy of heart failure and COPD quite similar because when an individual gets an exacerbation, it's almost like having a decompensation of heart failure, where all of a sudden the cardiac output for heart failure has gone down. And when they have recovered, their cardiac output never returns to the same level. And the same way with COPD, that when the lung functionality has gone down drastically as a result of an exacerbation, when they do recover through oral corticosteroids, through the blue inhaler use, and through other interventions, the lung functionality doesn't always restore back to the previous lung functionality. And this is that slow, gentle decline of patients and individuals' sort of tolerance, leading to a very prolonged and unhappy life because of their capacity being limited due to that constant decline, decline, decline. And we see that also, and Janni will also be, she's the first one to say she's also seen this in people with CKD. You see that long, gentle decline because of the nephrons basically being abolished because of the upstream pressures going downstream. So I think when we look at our patients with long-term conditions, COPD, heart failure, CKD, it's all in one same sort of pathology, the same direction of change. And unless you do something to improve your capacity, you're not going to get any improvement in that patient outcomes going forward. And when you're looking at our patients, you might see individuals of apart from the therapeutic interventions, that they get breathlessness. And this significant cycle of inactivity is a vicious cycle where slowly, slowly, slowly causes the decay and decline of that individual. So they might get breathless because they get fear of activity that increases breathlessness. They avoid those activities, thereby they become less active. The muscles become weaker, the muscle mass reduces, weak muscles use more oxygen and they are less efficient, like heart failure, less efficient, okay? And that's why they get more breathless. And then that cycle of inactivity, deconditioning, and decompensation, it eventually leads to the patient's untimely death. Okay, and look at your patients. Think about your patient who sees you coming in for a COPD review. We can't cure this person with COPD that you see before you, but if we could turn back time, if we could say, when this person was coming in with infections, with thick mucus, with cough, then potentially we should have said, could it be COPD? Let's do a spirometry. And we know that COPD doesn't live by itself. It lives in other with the vicinity of other comorbidities. So, heart failure, osteoporosis, any sort of ischemic heart disease, okay, anemia, potentially other co-comorbidities which mimic the same signs and symptoms of coughing, of breathlessness, of wheeze, and excess mutant production. So we need to step back. So we see John here coughing away. Okay, what could we have done to reduce the impact of this fellow if we were looking at him 10 years before today, or even 20 years before today? So this is why this job, ladies and gents, is a thankless job. Nobody's going to thank you for preventing something 10, 20 years down the line. But you know in your heart, as a healthcare professional, as a pharmacist, that you've done your right job at the right time to add years to life and life to years. Okay. And this is just something that we've got to start looking at from the long term point of view. And it's not just about exacerbations. It's not just about the impact, but also the financial burden, the ability to work, the ability to create relationships, to keep in touch with your mates, to go out, have a drink now and again with your friends or whatever, have that socializing, playing sports. All these are impeded and impacted by the virtue of not having well managed COPD. And it's the reason is very simple. The call to action for you guys is very simple. Early intervention is the best prevention. And together, my friends, we should make COPD sexy again, because we see it. How do we see it? We see it as oh, it's an old person's condition. Okay. It's an old person disease, but it doesn't have to be. And remember, you and I and everyone, we're getting there. We're becoming older in our sort of, pathology. So if we're not able to look after other people, what's the chance that someone else might look after us? Okay. So we need to sow the seeds of good clinical judgment and good practice and evidence-based therapeutics.
And another comment I've just actually had come through as well, which is probably worth thinking about with the
Mhm.
amount of patients who are now vaping, who are going quite intensely with obviously the vaping side, trying to give up smoking potentially, going and trying to actually we see it as a older person's disease. Actually, it's
Yeah,
not going to be long until it is deemed a much younger person and much younger prevalence going forward. So it's
yeah,
just something just to bear in mind that actually this is a condition that we don't tend to characterize until later on in life, but it is going to be something that becomes more prevalent at a younger age for us to look out for.
you absolutely. You know what, Shandi, you're absolutely right, mate. Because vaping, there's an issue with vaping, and the vaping is the government has said if you're smoking, you should vape because they're lesser of two evils. Well, what are we seeing now? We're seeing, high school kids, right, outside the school vaping as if they're Thomas the Tank Engine, never smoked a cigarette in their life, but they like the flavors. What flavors do they get? They get spearmint flavors, or the
Bubble
uh,
gum, double
bubble
apple.
gum, double apple, all these things which, it's very attractive, it's very sweet. And these guys are marketing towards children. Yeah, they're marketed towards children. And I'll tell you something, and this is going to be recorded, so it's good. A lot of the vaping companies, if not the majority of the vaping companies, are owned by big tobacco firms. So this is the direction of travel. They're going to make their money. The big tobacco firms, British American Tobacco, or Imperial, whatever it's called, Imperial Tobacco. These guys are going to make money off the habitual nature of human beings, and they are moving away from smoking because they know it's going to be killed by, they Rishi Sunak tried to pass a bill which I think is going to resurface again, about restricting sales of cigarettes, so they know it's going to happen. But they're investing in all these vapes and coal tar. And remember, if you think about when you're cooking some food on your barbie, yeah, say it's summertime and you're cooking food on your barbie, okay, the heat is going to sear that meat, or that, veggie burn or veggie patty or whatever it is that you're cooking. You're inhaling superheated gases into your lungs. What do you think is happening inside your lungs? It's going to cook. Okay. And it's going to have that high absorption factor, because heat causes the dilation, increases the absorption of whatever chemicals are coming through that mechanism. And you're going to get that instant high because of all the oils and such that might be going in there. And could you imagine what impact it's going to have? So today's vapors are tomorrow's COPD patients. They're going to be coming to you. I'm sorry about that. That's my rant for the day. I'm not going to
No, no,
rant
it's
anymore.
fine. I think it's very valid to say it's going to cook. I tend to say it's going to burn
Mm.
because you're killing it. So it's a, someone who doesn't know how to cook is going to burn the
It's
internal
going
because
to
they don't
burn.
because they don't realize the issues it's going to have. But back to your
Yeah,
talk.
yeah,
I
yeah.
just thought it was important just to mention that was all.
Thank you, thank you, thank you. So, what are we looking at? What is an exacerbation? Well, an exacerbation can be due to, and this is so important because we need to know what an exacerbation is and what the components of it is, but more importantly, your patient needs to know. So the clinical signs of an exacerbation is increased dyspnea, increased amount of sputum production, and increased amount of sputum volume, increased amount of coughing, and increased amount of wheeze. And as a result, this could be due to airway inflammation, production, and marked gas trapping within the actual alveoli and the bronchial tree. Okay, and we know the most common symptom of COPD is these four aspects. Okay, but at a more advanced stage, when we look at severe COPD, symptoms also can include other things in terms of malnutrition, weight loss, tiredness, swollen ankles, and we know from the progressive nature of COPD, these symptoms tend to get worse over time and have a massive impact on day-to-day activities, but also on other comorbidities that the patient may also be having. So if they got heart failure and they're prone to ankle swelling, they could potentially get ankle swelling due to COPD from a severe stage point of view. Okay, and we know over time that with significant sort of obstruction of the airways, they may be present either before the patient is even aware for it because it's already happened. The patient may not be fully aware that's happening, but they might be having signs and symptoms such as these four that you see. So this is why it's so important to limit and reduce the frequency and the severity of exacerbations and prevent the sort of uh, remodeling of the lung as a result. Because every time we have an exacerbation, like I said, you decompensate and it causes a change in your lung functionality so that you never revert to the previous lung function that you had. Okay. And we know with there's a number of different causes, and we've already spoken about smoking tending to be the primary risk factor for COPD. Um, and this is why we need to really address it from that point of view. And one of the things I'm thinking about in my sort of practice as a pharmacist is like, the government's all happy to give out GLP injections. Like they said, we'll give out GLP injections for those people not working who are overweight and whatnot. But really, truly, we need to start looking at it from a preventative point of view. Prevent COPD, prevent weight loss, okay? Prevent COPD, prevent weight gain, prevent the subsequent issues that might transpire as a result of all these things. So rather than giving everyone GLP injections, like like it's like Willy Wonka's chocolate factory giving out sweets, why don't we prevent the number of KFCs and fried food joints opening up near schools? And that will keep our communities more healthier because you're reducing access to the younger kids who will be your tomorrow patients with overweight, with COPD, with other comorbidities. So we really need to look at it from an upstream point of view rather than firefighting, which we've done so far, and it's so expensive. And we know, like we said, early intervention is the best prevention. And the early intervention for effective COPD management is through preventing exacerbations, okay? Reducing the symptoms, and these symptoms can be reduced by using relievers to relieve the symptoms, but also improving your exercise tolerance by exercising, by activity, and also improving your overall health status by engaging with other people. We also want to reduce of risk of or morbidity and mortality and worsening of the condition. And we do this by either ideally preventing and treating exacerbations early on, preventing that disease progression by getting on the right inhaler at the right time, but and also reducing mortality for these individuals. Okay. So if you look at it from a two-pronged aspect, reduce symptoms and you reduce risk, you improve overall outcomes and actually positively impact on that patient journey going forward. And we know that the fundamental management of COPD, like we said before, is smoking cessation. And every time you see a patient coming into your surgery for COPD, always ask because there might be a reason that they might have restarted if they were smoking before, or they might be in the environment of someone who is smoking currently. Okay, so it's important to have that intervention. Making every contact count in any long-term condition is super important. And these exacerbations will have a lasting effect on that individual. Now we know with exacerbations. We've spoken about the two-pronged attack of symptoms and worsening outcomes for that individual. We need to characterize what an exacerbation is, and we've defined it utilizing the new gold guidelines, which are currently in play, and which will look to maybe incorporate themselves at some form in the Southwest London guidelines going forward. So what is gold? I'll give you a chance to read. An exacerbation of COPD defined as the event characterized by dyspnea, cough, sputum that worsens within 2 weeks and could be accompanied by tachypnea, tachycardia, as well as associated with local as well as systemic inflammatory markers and caused by infections, pollutions, and other sort of insults or triggers in the airway. And this is quite important. So if you want to take a photograph, when you code anything on the system, what you put in is what you get out. So garbage in, garbage out. It's important to get the right coding, because the coding of your exacerbation will enable you to audit whether or not a patient is suitable for escalation in the therapy. So a exacerbation is where a patient has needed to use reliever medications, but they can do it within their own environment without any other issues. So reliever medications, so the blue inhaler. A moderate exacerbation would be seen as a person with sustained worsening respiratory status. Even though they've been using the blue inhaler, they may require either their oral corticosteroids or antibiotics to help relieve that. And that's also known as the rescue pack, which some patients have. And the severe exacerbation is basically a rapid deterioration in the respiratory status, requiring them to be admitted into hospital or be presented in hospital. So I think that's super important. And if you keep that in mind, it will give us a way of trying to distinguish what significance of severity of that exacerbation is, because then we will then be allowed to utilize that data to escalate therapies accordingly and in an appropriate manner, according to both NICE and GOLD guidelines, but also our local guidelines that we have as well. And of course, we know that the fundamentals of COPD, like we've already said about smoking, but we also want to make sure that from our point of view, we are keeping our vaccinations up to date, making sure we're making every contact count, stabbing them with the RSV, with the flu, with the pneumonia, with the shingles, whatever you've got going, COVID. The poor guys will be like, dartboards, no doubt, at the end, making sure that we offer those people who are indicated pulmonary rehab, making sure that we always provide, like we do with asthma, we provide patients with a personalized COPD self-management plan. And also we need to optimize patients' other comorbidities that could be mimicking the signs and symptoms of that of worsening COPD. Okay, and we'll have a quick chat about that shortly. So currently our guidelines, so this is what we use with current NICE sort of algorithms, and you'll find this on the current COPD guidelines as well from Southwest London. Okay, we tend to have a two-pronged attack. The first prong, which is what we try to do, is with LABA LAMA, and this is going to become more significant because of the evidence base behind it. But currently with NICE, it says if they've got no asthmatic features, meaning they've got they didn't have asthma before, and they don't have a raised eosinophil count, then it's most likely that they'll benefit from a LABA LAMA, because they would only have a steroid if they have a raised eosinophil count, which it will then they would consider for ICS LABA, or if they previously had asthma and that's kind of developed into COPD, they might already be on ICS LABA. Then depending on the severity, so if you're at the LABA LAMA route, and depending on the exacerbations that they get, so they get one severe or two moderate, then they might be considered for a triple therapy where you've got the components of the ICS, LABA, and LAMA in one. Or if they find that the person has got day-to-day symptoms that adversely affects their quality of life and that they're not able to do what they normally do, then again, a 3-month trial of the triple therapy is feasible. But if they don't get any benefit from that particular area, then they can revert back to LABA LAMA. If, however, on the other side, they've got asthmatic features, so they've got steroid responsiveness, and they previously were on, say, for asthma, and they were on Foster or whatever, they should carry on with that Foster. And if, again, they've had one severe, two moderate, or their day-to-day impact of their lives is significant, then they will go on to having triple therapy. And we do try to look at, try it out. And if you, because if you don't try, you don't know. But the benefit of having this triple engagement is that you are attacking from three-pronged attack, not only from a dual bronchodilator point of view with the lava lama, but also the anti-inflammatory point of view inside the lumen of the airway. And that obviously helps reduce risk, but also reduces symptoms that the patient would be experiencing. But going forward, and I think this is where maybe we're going more towards, where if NICE is saying we're going to be limited by symptoms, then NICE is saying, if bronchodilator, they're using having bronchodilator, so they're on SABA alone, then we should be utilizing LABA LAMA definitely, especially if their dyspnea scale is two or more for the modified dyspnea scale, or CAT score greater than 10. But Gold is saying, yes, we can do that, but also if they're showing mild symptoms where it's quite relatively low, then we should carry on with the blue inhaler. And remember, when we're looking at the blue inhaler for patients with COPD, because they don't get that reversibility, they have to use something to as open, even to a small degree, to reduce the risk of infections and breathlessness. So that's why in COPD, they tend to use the blue a lot more, and it's permitted to use a lot more. But if they're using significant amounts and they're not on any other therapy, then you should look at using dual bronchodilators as a means of attack from both sides. But I think when you look at it going forward, both Gold and NICE, we know that they align on the recommendation of dual bronchotherapy, and I think this is the direction of travel that we'll be seeing for our Southwest London guidelines. And as a result, we should be focusing on that more so. Now, and I know we've got patients who are on LAMAs, okay, on tiotropiums, whether it's Braltus or Tiogiva or whatever, Spiriva, and although they might be well established, there's no reason to change them if they are well managed. So don't, if it ain't broke, don't fix it. But if they are having exacerbations, or if they're getting wheeze, or the quality of life is being impacted, then it's well worth trying out on LABA LAMA to help alleviate the signs and symptoms for that individual. And we know also the use of ICS LABA is not encouraged according to the GOLD report of 2024 in COPD. And if the patient, obviously, as it says, with no features of asthma has been treated for whatever reason, then we should be considering, if they're already on it, then you should carry on with it. Don't upset the apple cart, but try and consider, and you can use a trial of LABA LAMA for those individuals going forward. I guess in a way, the use of ICS, inhaled corticosteroids, is trying to minimize in the use of COPD. I mean, I know there's a consideration of the risk of pneumonia going forward, but to be honest with you, the relative risk of pneumonia from inhaled corticosteroids is far less than that of oral corticosteroids going forward. So the next part would be looking at the follow-up sort of. So we've done the initial sort of engagement with where we use SABA or SAMA if it's not available, and then moving down to LABA LAMA or ICS LABA. And then when we look at follow-up pharmacological treatments after the initial therapy, uh, we need to find out, well, if the initial therapy ain't working, why not? Okay. Is it because of adherence? Is it because of technique? Is there other interfering comorbidities that are mimicking the signs and symptoms of what the patient's experiencing? And then look at how many severities of exacerbations that individuals got, and the number of severities they're getting as well. Gold, in fact, says look at also blood eosinophils if it's greater than 100, and recommends then, as a result, we should then escalate patients to having triple therapy. And if you find that the limitations due to more symptoms than anything, so they're not getting exacerbations, but they might have a high COPD CAT score where they're not able to, live the life that they love and do the things that they want to do, before you escalate, try optimize non-pharmacological management, look at other causes of dyspnea, look at trigger factors, breathing exercises and whatnot. And if still there's no benefit, then we can consider a trial from LABA LAMA to ICS LABA LAMA, just as a trial for 3 months. And if it doesn't work, then we can go back going forward. Cool. So I guess when should we consider ICS intervention? And this is why Gold is skewing more towards a LABA LAMA side, things like a NORA and stuff like that. We should consider only having inhaled corticosteroids if there's a strong history of hospitalization due to the exacerbation. So there are routine offenders going in and out of hospital because of these exacerbations. They've had more than two or moderate sort of exacerbations of COPD in the last year, and the blood eosinophil counts are greater than that of 300 cells per unit liter. And also there's a history of asthma. It slightly flavors the use of ICSs if the patient's had one moderate exacerbation of COPD in the last year, according to evidence, and if the eosinophil counts are anything between 100 to 300. And it's definitely against the use of ICS in patients with COPD who have got repeated pneumonia events to reduce the risk of them having frequent pneumonia. Obviously, you don't add insult to injury if they're already at high risk of getting it all the time, or if their blood eosinophil counts is well below 100 cells per unit liter. And also they might have an increased risk of mycobacterial infections. Um, so, it's a gold mine. It's a minefield out there. There are so many inhalers, and I'll be honest with you, there are more inhalers going to come because of Me Too drugs, Me Too companies trying to copy and paste what other companies have done already because of asthma, COPD, and the indications of which. And if you can just think about like your patient who might be potentially already on a triple therapy, but they might be on different inhalers. So they might be on, say, for example, a Llama like Braltus, the green one at the bottom left, they might be on a Foster, say a PMDI on the top right. Okay, the technique, the management, the ability to use the dexterity of it in these patients who are already at high risk of other comorbidities, also like arthritis and stuff, maybe even memory issues, it makes it more complicated. And this is where, for example, where polypharmacy also can be a burden on that individual because they might use the inhaler the wrong way, the wrong time, and may be forgetful as well. So we need to simplify it for our patients to ensure that we're getting the best outcomes for those guys. And I know a lot of our colleagues might be saying, yeah, but my patients can't use dry powder inhalers because of they're not able to suck it in. And to be honest with you, if you use the injectile, you'll note that PMDI is obviously being the least resistance. So you don't need a lot of inspiratory flow in order to deposit the medications deep into the lungs, and it gets slightly more resistance when you're looking at things like Breezhaler. More than that, it becomes Ellipta. Then you got your Turbohaler, your Clickhaler, Turbohaler, um, and your Nexthaler, and then your Handyhaler. So funnily enough, that we got Handyhaler right at the most resistance, and that's obviously a dry powder inhaler for tiotropium. So it's something which, although we need to have consideration for, you know, the fact that it's a dry powder inhaler, as sustainability agenda, comes into play with our prescribing habits, we should be thinking more openly and say, look, if you're able to do it, get a placebo, get them to try it out, and you find that, if they can suck in quite nicely, they'll be able to have that lung deposition without any issues. But if you don't try, you won't know. And that's a nice blank screen. I'm not sure why, but anyway, from the fundamentals of COPD care we mentioned already. So always have it at hand. We spoke about smoking, we spoke about vaccinations, we spoke about pulmonary rehab. We need to be aware about self-management processes through Asthma at Lung UK, and they've got an awesome, absolutely awesome section on your COPD management plan, and it really is amazing. So download it, send it to your patients via AccuRx after you filled it in, and also look at the patients from a holistic point of view. It's not just lung issues that they might have. Other things could be in play, which could be interplaying with those individuals going forward. So we need to look at from a very holistic approach when we're seeing our patients and optimizing their treatment for comorbidities to reduce the impact for that individual. And look at the social history as well. Be tactful, find out more and say, look, these sort of things I'm asking because it can interplay and interfere with your lungs. Do you shisha? Do you vape? Do you smoke cannabis? And this only helps your narrative and helps your sort of management of your pathway going forward for these individuals. And it's not just us. We're not like looking after the whole COPD world as a profession. It's a whole and multidisciplinary team approach that involves a team of healthcare professionals working together, providing a comprehensive care package for our patients with COPD, and that could be from any stage, any part of that pathway. So it could be the early detection and diagnosis, like we mentioned already, smoking, we mentioned already pulmonary rehab, but also reinforcing self-management. So if you're going to be prescribing a new inhaler, say the triple inhaler, for example, uh, you prescribe it, you tell the patient a lot of stuff, they get the prescription from the pharmacy, it activates a new medicine service, then the pharmacist there would hopefully activate that NMS and if have that engagement initial and then the final sort of engagement to make sure that they're getting the best out of the inhalers, they're using it regularly, there's no issues with side effects, they're seeing benefit, and there's no red flags. Okay, but apart from therapies, looking at also psychological support, because the anxiety, the depression that comes with COPD is super common, and we can't underestimate that, because remember, if you can't breathe, you can't live. Okay, so this can be quite a concern and restrict the day-to-day life of our patients going forward. Look at social prescribing, look at community support, look at referring patients to breathe easy groups, which is charity group which has support mechanisms in place for people with COPD, so people can learn more about it and also have that peer-to-peer sort of learning process going forward. And regularly follow up these guys. Don't just like say, here's your new inhaler, okay, off you go, see you in about 6 months to a year or whatever. We got to have that sort of like catch up points, because they're more likely to use up your appointments and also more likely to be a burden on the NHS in terms of constant admissions into A&E and being hospitalized. And we need to prevent that, because it's your money, it's my money that's going into this. So early intervention does definitely make a good prevention. And one of the things, a big shout out to your pulmonary rehab, because they are absolutely amazeballs. Okay, if you've not ever had a chance to refer, please do so. Anyone with an MRC grade of 3 or more would be eligible for pulmonary rehab in Southwest London. But speak to Sue Langley, speak to Dan Davis. They're absolutely amazing, and you learn so much. And when I did my prescribing course in respiratory, I was engaging with them. I was finding out a bit more, and they are absolutely amazing about what pulmonary rehab can do. And it's these simple techniques. Don't just medicalize, exercise, all that sort of things which, come into play. That why we burdening you with extra therapies when we can help you with simple techniques to reduce your breathlessness by angling yourself forward on the desk, or sitting in a particular position which will open up your lungs, or doing pursed breathing, or even having that fan close to your mouth which activates it from a neuroreceptor point of view and opens up your lungs and relaxes your mind as well. So all these sort of interventions, absolutely mind-blowing, and that's what we need to be looking at as well. Uh, Going forward. So I guess from a monitoring point of view, when we have initiated someone and we are making sure that they're getting their therapies, we monitor for symptoms, we monitor for exacerbations, and we also monitor for airflow obstruction, especially if they're severely significantly have COPD, significant COPD, and which is changing quite rapidly. We might need to keep them on the spirometry list on a yearly basis just for that period of time, so we can see what direction of change is happening before we make that referral. We also review cough, sputum, breathlessness, fatigue, and activity limitations, as well as sleep disturbances as well. We have got a form which you can find on your Ardens, or you can Google it as COPD CAT score. I think GSK have sponsored it, but it doesn't matter. It's super easy to fill out, and you can also get it on AccuRx and send it out to your patients if you just type in COPD CAT, and it gives you an idea of what the smoking status is, what the cigarette pack years are, as well as any other issues that they might be experiencing. And what we're looking for is frequent exacerbations, severity, type, and likely causes as well going forward for that individual. Here's the example of that CAT score. Simple questionnaire designed to measure the impact of COPD on a person's day-to-day life. Consists of 8 questions, and each scores from 0 to 5, where higher the score, the more severe or significant the symptoms and the greater impact to daily life. And the CAT score also helps with us as healthcare professionals with identifying how severe their COPD aspects are and tailoring that treatment as part of that sort of personalized COPD management plan. Make it personal, personalize it by utilizing this. So if it's, for example, cough, then you know it's more of a cough issue. You know, if it's breathlessness, you know it's more obstruction. You know it's going to be activities, day-to-day life. You know, it could be again breathlessness, or it could be increased amount of sputum production or infections. Then you know you need to get some sort of mucolytic in there to help shift that phlegm. So it gives you that sort of idea of how they are, what they're doing, and where the interventions can be made. Super important. And this is the dyspnea MRC grade, which measures the perceived degree of respiratory disability caused by breathlessness. It's basically used to help characterize the baseline dyspnea of patients and allows you a measured way to see how they are today compared to how they will be in the next 6 to 12 months, and if symptoms have improved. And it's just basically about what's the capacity at that time compared to what it is. Now, there are two types of grades. One is the MRC grade and one is the modified MRC grade. We tend to use MRC grade, the one on the left, 1 to 5, on our EMIS systems. And I think that's, yeah, that's what you also get when you send out the COPD CAT score, which is also embedded in that questionnaire when you bring it back. So an MRC grade of 3 or more would prompt you to offer pulmonary rehab. But if you feel that a patient who's got a MRC grade of 2, who may still benefit from a pulmonary rehab, it's still worthwhile making that referral with your explanation as to why you think that might benefit, because of the significant amount of breathlessness that my patient will be getting. It's always good to have that intervention. And that's that asthma lung COPD management plan. Please look to download it. It gives you a toolkit in your narrative, because as you can imagine, like you must be like me, I'm giving out like 100 bits of information, like a machine gun to the patient. And as a result, they're only going to take out a significant amount of that, not even a vast amount of that. So like your asthma action plan, the COPD action plan will also put your words into the booklet, and also advise and inform the patient of what to do next should things get worse in their symptoms or the medication, or how they should be managing their breathlessness, and top tips to prevent and managing flare-ups as well. And I think that gives that sort of viability for that patient to take responsibility for their own health. And one of the aspects of that COPD management plan was, what do I do when I feel worse than normal? And I thought this is quite significant, because this plays nicely with the classification of exacerbations. So if your patient, if you look at the left-hand column of the 4-column chart on the left, if I get more breathless than normal, I will start using my reliever inhaler more. And that would be considered the red mild exacerbation, because they're able to manage themselves in their own environment. However, the next column is, if I get breathless despite taking my reliever medication, I will start using my rescue pack steroids. So this would be considered the green one, which is the moderate exacerbation, where they're now having to use or oral corticosteroids, despite using the blue inhaler with no avail. The third column is, if they get more phlegm change, or more coloring, more phlegm, or the change in color, which is dark yellow or green, then I will start using my steroids and antibiotics. Again, moderate exacerbation because of the antibiotic use. And it also gives a patient an idea of that if they get an exacerbation, they don't always have to use both antibiotic and steroid all the time. That maybe the steroid will be sufficient in curtailing that exacerbation earlier on, because there's no sign of infection. And this is how we can reduce antimicrobial burden and improve our stewardship in antibiotics use. And if they get more chesty, coughing, keep calm, use ways in which they can control their breathing, such as what they've been taught maybe in pulmonary rehab, which also the booklet will show on how to manage themselves. But if they become significantly unwell and it becomes significantly bad, you know, that's a severe exacerbation which requires hospitalization going forward. So I found that really useful because it coordinates with what we're going to write on our email system with what the patient is experiencing. So I guess the top challenges that we face today, ladies and gents, is the diagnosis of COPD in the early stages. We know is a massive challenge. It's super limited, and COPD is all too often diagnosed with when severity has increased. So, the bird's already out the cage. It's already out there. So we need to seek opportunities to intervene before having lung function being severely impaired. And this could be, they might have, like, for example, heart failure. They might have anemia. They might have diabetes. Okay, we know that there's a cardiopulmonary link that can impact on the different systems because of the one system that we've got. So we should always be looking at, could it be COPD because of breathlessness and sputum production? And because of this awareness of common comorbidities, we need to also make sure that there could be other conditions which have similar or mimicking the symptoms of that of COPD, like we said, of heart failure, ischemic heart disease, arrhythmias, and also, like we said, regarding the connection between the cardiopulmonary link. And we know also from the patient's point of view, those individuals who present with COPD exacerbations could also have a pre-existing of anemia. So this is why it's important to do full blood count to check the ferritins and such, the red blood cells and the hemoglobin. But also it'll give you an idea if there's any sort of raised eosinophil counts in the same sample going forward. But we also know it could be psychological, it could be anxiety, it could be depression, it could be cognitive impairment, or poor adherence to whatever therapies that they're using, causing an impact. So I hope that's good. I hope you enjoy
Quick
it like
question
that.
for you,
Yeah,
Darshan, if
go
that's
fire
okay.
away. Yeah,
So,
yeah.
oh, I had a comment that's come through and a quite query that's come through in the chat, which I thought I'd just quickly challenge with you.
Yes.
I think I know the answer, but I'm going to let you answer it because you know the
Okay.
area better than me. So,
Okay.
according to this, something that someone has said is that once spirometry has been done and COPD is confirmed, then is there no need to ever do spirometry again as COPD is progressive? Would you be able to comment on that?
So COPD is a progressive condition.
Hmm.
It's going to get worse if you don't manage it properly. It's like your heart failure. It's going to get. It's not like your heart failure is going to be okay. My heart's failed at a certain level, and it'll always be like that. COPD is a progressive nature. As we get older, the lungs are getting older as well, and it causes that sort of cycle. So where I would consider a repeat spirometry is if there's a significant decline in their lung functionality, which might prompt further monitoring of that person. And it could be something that you might want to refer straight off because you found that this person is exacerbating, getting wheezy more so, despite you intervening with therapeutic advances or non-pharmacological interventions. They would need to be monitored to see what other things could be happening and to give you a sort of trend, because like when you see a trend for diabetes or lipids and such, you see how it was before, during, and after, and you can see the direction of travel. And sometimes you might need to do that. So yes, the spirometry will confirm your diagnosis of COPD, but it's those individuals with a progressive, which is significantly progressive, not the natural progression which one would get as a result of age.
So, just to clarify, so we would get it for essentially the spirometry confirms COPD. Once it's
Correct.
confirmed, we don't need to repeat the spirometry for confirmation
No,
of diagnosis. It's just a
no,
once off that's done.
that's a once off. But it's those people with
Exactly.
severe COPD.
Exactly that.
You might be inclined to do a repeat one, um, just to see where the trend is going. But you'll be liaising with your secondary care colleagues anyway.
And often enough, those people are going to be people who have had severe exacerbations, severe changes in kind of their health, maybe have had COVID in between, actually had severe decline in itself. Those people will be worth repeating to see actually, is there actually any basis for other therapies that we not be able to provide. For example, where oxygen therapy is indicated and those kind of things where
Yes,
secondary care would be getting involved. So for those
yes,
people, we would definitely repeat. For just for
yes.
confirmation for the diagnosis, once off is fine.
Once off is fine, then we know
Perfect.
what it is. Now, I've had a few patients where I've had to get a repeat spirometry done, and this was done maybe after a few years because of their constant sort of exacerbations. They were like, revolving door patients coming into the surgery, going into hospital, and I wanted to check what else was going on. I made a recommendation because I optimized their therapies to the maximum that I could do in primary care. And I think, my thought was, and I haven't touched upon it today, but, patients could also be considered for rofibrillast, antibiotic therapies such as azithromycin 250 3 times a week, potential use of morphine sulfate to help reduce the anxiety and the impact
Breathlessness.
of breathlessness, and potentially lorazepam as well. And now the future, we know with severe asthma that patients can be referred for monoclonal antibodies. There's trials being done for that use of monoclonal antibodies in COPD as well. And so that could be another intervention that we could potentially refer patients into secondary care to address that sort of cascade events that lead to IL-2, IL-3, and all those sort of mediators that causes that inflammation and that sort of like fixed airway issues that we see in our patients.
And I think that's something that I think Spectra is working alongside with as well, which we are
Yeah,
looking at slowly across South West London in little pockets of areas.
yeah.
But yes, that's our questions. Thank you so much.
Thank you. Oh, cool. So moving on to how do we put the evidence into practice? So we know what the guidelines say. We know where the best practice looks like. We know that it's not just about drugs. It's about the lifestyle, the diet, the exercise, the smoking, vaccinations. We know all that now. We need to put it to practice. So I want to introduce you to a patient. Let's call her May. Okay, May is an 84-year-old female. She has got COPD. She also lives with osteoarthritis, glaucoma. She's had cataracts done, so her vision, obviously, you can tell, may not be so great. She's also got hypothyroidism, endometrial cancer, hypertension, and she's got mental health issues. This has worsened, especially since the passing of her husband 5 years ago, and now she lives alone in a semi-detached house. Okay. She's an ex-smoker of over 40 years and has a smoking pack years of about 20. Her symptom control is quite poor. She's excessively using the blue inhaler and she gets frequent exacerbations and has a rescue pack indoors. So current therapy from an inhaled point of view is Foster, has 2 puffs twice a day as a PMDI. She also has Lama as Braltus, 1 puff a day, and she also uses the blue inhaler, currently using it as 4 to 6 puffs a day, so quite an excessive use. Okay. What would your thoughts be about this individual? What would your interventions be initially? And please, if you can put it in the chat function, if you had this young lady, May, 84-year-old, okay, what else do you want to know? What else would you want to find out?
There's a lot of different things that are going on in my head, but we're going to let everyone else go and
Mm,
practice. So if you pop it into the chat, guys, I'll read out your answers as we go along.
thank you. Thank you.
So that makes it easier because I know that Darshan Blessing can't see the screen on that front. So I think
I'm
it's
like
just
I'm like Stevie Wonder. I can't see anything.
there you go. I didn't really think we wanted to make that comment one, but that's fine. In terms of that, so we've got someone who said consider switching to triple inhaler for one
Okay.
inhaler, which is an option.
Okay. Why
Someone
would you
said
do that?
so potentially to optimize, I'm assuming, one because of the South West London agenda for change,
Hmm. Hmm.
trying to make sure we're using inhalers appropriately, make it
Hmm.
easier for the patient, for better for compliance as well.
Hmm.
We've got someone who's commented other medication. Another person said diet. Are they eating, drinking side on that front? Have they got
Hmm.
heart failure? Is there any breathlessness going on?
Hmm.
We've got another person saying, what's their MRC score?
Hmm.
We've got another person saying offer smoking cessation, as well as have they had their vaccinations on that
Well,
front?
they're an ex-smoker, so
Ex-smoker, so we
yeah,
don't need
yeah,
to offer that. That makes
yeah,
life easier.
yeah,
Hopefully they haven't
yeah,
restarted.
yeah.
We've got another one saying check heart function. Is any
Hmm.
ankle swelling? Are we thinking heart failure?
Yes, yes.
Chest x-ray for differential diagnosis.
Hmm. Hmm.
Can she actually use the existing inhalers properly is the other
Yes,
thing.
exactly.
Thinking
Fantastic.
about mold, dirty home, environment. Has she tried
Yes.
pulmonary rehab? Everyone seems to be listening to you, Darshan. It's quite nice.
I love you guys. You guys are like my besties, honestly. Or
um,
you make my heart happy. Thank you.
So there's more yet. So is she using a spacer with a PMDI?
Okay.
Or could she benefit from a dry powder? Has she got a
Yes.
mixed picture of COPD or mixed asthma COPD? And
Hmm.
that is the end of your answers that you've had.
I really like that. That's really good. In fact, the really comprehensive approach, because this young lady, and she's a real patient of mine, I had to visit her at home. She's a housebound individual, doesn't have any help at home. Her husband passed away, like I said, 5 years ago. Son lives in Bournemouth. Their daughter lives somewhere up north in Newcastle, somewhere outside of the M25. And effectively, she is fending for herself. She's just about being able to do shopping by the help of a neighbor, or she's trying it on the mobile, where you get that Sainsbury's online stuff. So yeah, so this lady, I went to do a flu jab for her to get it done, and I found that she wasn't even seeing her inhalers properly because of poor eyesight, and because of osteoarthritis in the hands, she was having difficulty pressing the inhalers, right? So and at the time she wasn't using a spacer. So yeah, she felt, yeah, I've been using Braltus, I'm not getting any benefit. I feel my lungs are getting worse. I'm housebound. I feel like I'm not confident leaving the house because of the paving stones. The council is not, they're taking all my money, but they're not fixing the paving stones, so I'm risk of falling. And also my surgery is up a slight incline, so she feels she's precluded. When I got her to stick her tongue out, I saw that, yeah, man, it was beautiful there. It was like, candida all over the place, right? Um, I assessed her from her COPD CAT score. COPD CAT score came up as 30 out of 40, which is quite significant burden. And the MRC grade was 4, which is a high degree of severity in her breathlessness and limitations imposed by that. And of note, from specifically looking at COPD CAT score, she was almost maxing out on poor sleep, poor significant amount of breathlessness due to her lungs, cough due to that, and phlegm. And because it was winter time, right, recently when I went to see her, it was cold. It's muggy. It's you can smell like certain odors in the house. You don't know who's cleaning the house. And I said, you live. You got a whole house to yourself. You live by yourself. So who lives upstairs? Who lives with you? And she goes, no, I live by myself. But because since her husband passed away, she hardly goes upstairs anymore, and she now sleeps on the couch or sofa because she gets breathless going up the stairs. So significant impact, not only from the person's longevity in life, but also for that issue individual. So from a shared decision making point of view, she was open to the fact that maybe she wasn't using it properly because of the candida in her mouth. She was happy to stay with a PMDI because at that time she thought, if I press it, I know I've got it in my lungs and I feel reassured. So I said, yeah, fine, it's your lungs, your life, let's try it out. So she wants to stay with the PMDI, but she was happy to change her Foster to a Trimble. She also, so I got rid of the Foster, I got rid of the Braltus, and also I gave her a spacer device to help optimize it, as well as a oral meconiazole gel to help get rid of the candida that she had because of the significant mucus that she was experiencing from her COPD CAT score. I gave her sort of carbocysteine. Now, the evidence of mucolytics is pretty poor, not that great, but it can be used off and on as a PRN med. So the maximum speed is 2 capsules 3 times a day. But remember, or polypharmacy and the impact of those extra tablets and yeah, carbocysteine. I mean, Shanti, these tablets are like horse pills, right? You swallow one, it's like it's stuck in your throat. And she's not a big lady; she's quite a frail old lady. I also made a referral to um, respiratory because of her uh, MRC score being 4 out of 5, grade 4, so significant impact on her breathlessness, who are happy to see her at home and to find out about mucus clearance techniques and also breathlessness techniques as well, to see if it helps her. Um, what else did I do? Yeah, and the carbocysteine we decided as acute, it wasn't going to be long term, but it gives her the option that if she gets a bit mucus and she's having difficulty, because a lot of patients with COPD tend to find that they get mucus which is like string-like, like PVC glue, quite thick, quite stringy. So when they're spitting it out, it's almost like dangling from their mouth. You know what I'm saying? The kind of mucus that you really don't want to be seeing. But it's important for them to describe it to you as healthcare professionals, because if it's like that coming out, imagine what it's like inside the body, all congealed goo, basically, quite sticky, thick congealed glue, a perfect habitat for bacterial infection. So we need to try to help clear it out. Steam inhalation and all that, mold advice. So we got involved with Age UK, we got involved with pulmonary rehab, and we got involved with social prescribing to help with that sort of care package of care for that individual. And as a result of being on that triple therapy, using a spacer, she feels a lot easier using it because she's always used to using a PMDI. Maybe when she feels very confident with me, I might try her on a dry powder, see how she feels. She's now able to get into the garden and do a little bit of, like, potting around like they do, just to maintain whatever. And now also she does a little bit of like sweeping up, hoovering and stuff like that, so she feels confident in doing that sort of day-to-day activities. She's still not confident leaving house, and I don't blame her. I'm not confident leaving my house, but hey ho. Um, because of the inclines and the uneven platforms and pavements. And also, I had given her a rescue pack, and I said, look, this is what you need to do as part of that sort of breathlessness scale. And if you find the blue don't kick in, then you can start using the steroid. And if steroid don't work and you're getting it colored, then steroid plus antibiotic. And if that doesn't work, then breathlessness exercise. But if you're feeling unwell or a significant detriment, you got to call 999. Always safety net, always safeguard your patients to let them know when things go pear-shaped, what to do. And obviously the technique with the spacer was perfect. I went again a couple of weeks later, tongue was beautiful, a nice pinky color, and no issue, no concerns there. So I guess my call to action for you guys is really, we need to diagnose these individuals early at other interventions. And I know we've only get 10-15 minutes of the time, and pressure is high, but if we don't see these people and if we don't ask the right questions, then ultimately we could be missing a trick, and that person might not come back again to see us until next year. Right? We need to make sure that any therapy we provide, we are personalizing it to that individual in terms of their medication and inhaler, that not only are they willing to use, but they're able to use as well. And think about things like memory capacity, dexterity, all those things will impact on how they use their inhalers and when they use their inhalers to ensure optimization of their lungs. And also, as part of your COPD management plan, involve families as well, like, that they're happy to involve, so that they have someone to prompt them to make sure that they're using it, and also someone to talk to if things getting a bit pear-shaped. And hopefully that will also help with their adherence point of view as well, from their family members. My best friend is Alexa, and Alexa tells me when to use my inhaler. So me and Alexa get on nicely, and she nags me quite a lot, actually, Alexa does. But anyway, so current guidelines, remember, uh, the majority of newly diagnosed COPD patients should be initiated on dual bronchodilators, LAMA-LABA, based on evidence-based to relieve symptoms. NICE recommends the use of ICS-LABA as monotherapy for patients who may have asthmatic features at this moment in time, until the new guidelines come into play, and then we can see how we can navigate those patients going forward. But yeah, so NICE use ICS-LABA only if the asthmatic features and the steroid responsiveness. So again, looking at eosinophil counts, if it's raised, which gives you that sort of indication as well. And remember, ladies and gents, you are not in this by yourself. A collaborative approach is needed, and make sure you speak to your social prescribers, make sure you speak to your pulmonary rehab teams, and speak to each other on this network to get the best outcomes for your patients going forward.
Thank you so much, Darshan. And I think that's actually been really insightful. And I think there's been a few comments that have come through saying, actually, thank you for bringing up about the carbazistin, because me and you have discussed this before, but I don't think it's
Yeah,
known to the wider population that it can just be used PRN for when the
yeah,
patient doesn't need to take them all the time. They can use it PRN just to kind of clear the
yeah.
mucolytic down, to thin it down effectively. So that's actually something that's come out really positively in the actual chat as well, that it can still be used just PRN, doesn't need to be all the time for all
No,
patients. So it's using it what's appropriate and then stop if it's not needed. Have had a
exactly.
query come through, going from what your evidence base is actually saying, just for that case in particular. Is it possible that actually that she scored high on the CAT and the MRC due to not being able to take the Brautis? And any reason you wouldn't have gone for the LABA-LAMA combination rather than going straight to triple therapy? That was the
That's correct.
question that came through.
So what I would have done, because she was already on ICS LABA, okay,
Mm,
and she felt semi all right. She felt there was a benefit from that, because remember, the patient's the best historian for their own condition. You're
absolutely.
only there to be the to take that information. Okay, so there are two experts in that sort of consultation. The patient is a super expert because they're already on the ICS LABA, and because of the exacerbations and wheeziness and the constant sort of need for using things like the blue inhaler, it was seen fit that they should carry on with that ICS LABA regimen with the addition of
Absolutely.
having a LAMA. Now, we know from Braltus that potentially it has a slightly higher resistance, okay,
Mhm.
when you're using it from a inspiratory flow rate point of view, from as part of that Clement and Clark chart that we've got. And because look, she's a frail old lady and she wanted to use that PMDI over dry powder. I did sell it to her, but she wasn't having none of it. She told me to bugger off afterwards. I said, look, okay, I won't do anything. But try this out. It's the same thing as what you're using now. It was a natural sort of progression. And I'd rather she use something than
Then nothing.
suffer, than, lose faith, lose hope, and she might not even engage with me. So it's very much a negotiation, isn't it?
It's that shared decision making, which is what
That's
everything
it.
comes down to. You want to make sure you're doing what's right for your patient based on what then. If they don't engage and they disengage, you've lost them at that point.
That's it.
A lot of other people coming out and saying, brilliant presentation, thank you, Darshan. So I think you'll be
Thank you,
coming
thank
back
you,
to
thank
do
you.
other bits and bobs for us, knowing us.
Yeah,
We'll
yeah,
drag you back to come and do another session for us.
pleasure.
And I think that's really important. I think it's about doing what's right for your patient. You know your patient when you've got that patient in front of you. No one else is going to
Yeah,
know that patient. And it's justifying them. Something I actually found was really insightful when I looked at the new guidance that's coming through as well is actually there's no place for Braltus anymore. Braltus isn't even on the agenda when we're looking at
no,
this new guidance coming through. So what you've got hundreds, if not thousands of patients across the whole of Southwest London who are on Braltus as a first
that's
line
right.
therapy who shouldn't be. So it's something just to think about. And that was something we
Yeah,
spoke about in terms of at one of our PCN meetings as well.
yeah,
That actually, if you're looking at it, first line is Lama Lava. It's not
that's
by
it.
itself.
But I think before, and like we had that IF sort of work stream before when a couple of years ago to say people who are on what we call an open triple should be on a closed triple where
Absolutely.
everything should be in one unit. But
It
if
didn't
they're
work for
on,
everyone.
no, it didn't work for everyone, and
Yeah.
it's very individualized. But
Mm,
look, if they're well managed on Llama, don't rock the boat.
absolutely.
Just
Absolutely.
chill. And
Just
if they come in with two more moderate or one severe, then you can say, then you need to say, okay, we need to escalate you. But if they're on ICS LABA and they're keeping healthy, they're doing the things that they love and loving the things that they do, and that's what we all want in life, isn't it? The square end of life. You know what, Chandni? We all have to die. Or each one of us.
well, yeah, let's not go down that route. A bit
No,
close
I'm
to
just
home right now.
no. Yeah. Oh, sorry. Well,
No, no,
no,
it's fine.
meaning what I'm saying is that it's the quality of our life that we want to achieve, and as
Absolutely.
clinicians, we can never prevent these things. We just
Absolutely.
improve the quality up until then, isn't it?
Absolutely. So, based on everything that we've gone through, we know Southwest London is in the process of being updated. Nice is also in process of being updated with what's going on because I think it's 2019 from previously
Yeah,
that it was updated with. I think there was a caveat in 2021, I think, but I could be
yeah.
wrong on that front. In terms of the guidance, which one are you going for at the moment? Kind of with Nice, Gold, Southwest London. Where do we stand in terms of in your
Yeah.
practice?
So, as pharmacists, generally, we are a very risk adverse bunch of people. Okay, don't go outside your Southwest London guidelines, okay? Because they're based on good practice, evidence based, and they might give you a bit of an amalgamation of between the two of gold and
Absolutely.
nice, which is fine, but that just gives you more sort of maneuverability. Nothing is not it's the things are not like DOAC. Like DOAC was very protocol driven, yeah.
Black and white. That's
Black and
it.
white. Yeah, EGFR this, creatinine clearance this, this and that. You can't have this, you can't have it. Whereas with respiratory, it's a lot about the symptoms and signs and patient sort of alleviation of those sort of conditions. And we've got to use that, use your ears, use your sort of person-centered approach to get to the right outcome, utilizing whichever gold or nice that you like. But remember, nice is mostly about cost effectiveness, cost saving. Yeah, I mean, like why in asthma they prefer to use Montelukast quick before using Laba, ICS Laba, because ICS Labas cost like 30 quid a month, whereas Monty costs only like what, £1 20 per month. So, be pragmatic, but look at the person in front of you before you make that choice.
Absolutely. Thank you so, so much, Darshan. I think that's been really inspiring, actually really eye-opening for all of those people who've just joined. Now I'm going to go and open this up. So if you haven't already, can you please jump on to our Menti because I know that we've had people go and already discuss this, but we want a bit of feedback from our lovely Darshan, and hopefully a bit of positive feedback. So I'll put my responding as on. So if you haven't already, I need you to go on and to go and say onto your MNT, put it on onto there. Your code is 38543910 on that front. And on that front, how did we find the session? So 7 of you have come back, which is great. Hopefully you're all still here, which makes my life easier on that front. If you haven't, if you can just jump on and make sure, obviously, we feedback in terms of kind of how we found the session. Darshan, spot on. Everyone seems to be saying it was just right. No improvements, no changes, no nothing. They like the session so far. So
Lovely jubbly.
yeah, there you go. We need some more gold only fools and horses comments though, especially this time of the year. We're coming close to Christmas.
Oh, I dive.
And it's how we do it. So we've got another minute or so, I'm going to say, on there. So on that front, just so that we can go make sure we get that feedback that's there for Darshan as well, just so that he knows how he did on that front. And actually, I think it's been a really insightful thing because I think going and applying it to a patient and making it specific makes a big difference. And I think you've tailored it really nicely to a lot of us to be able to go and make sure on that front. I've got on here, can we do another session with more case studies, please? That's something
Yeah,
we
I've
can
got loads of
potentially
case
learn.
studies. Yeah, with COPD, even asthma, like because our asthma. So just to let you know, BTS Sign are going to update the asthma guidelines nationally on the 27th of this month, and this will then transpire down to us in community in primary care, and it's going to focus on things like as air and MART therapy as the mainstays of therapy. And I think
Big drive going
once,
down the Mart side.
yeah, and I think, it'd be good to look at best practices and maybe have a few um, case studies that would help us navigate those individuals so we can almost sell it to the patient to say, this is going to be better than sliced bread, but this is how you need to use it. And, like Spider-Man's uncle said, Chandni, with great power comes great
Comes great
responsibility.
responsibility. Absolutely.
That's it. So we need to use these things responsibly. Can I also suggest if there's any colleagues, if they're more than welcome to uh, BTS. So John, it's
BTS sign.
BTS, British Thoracic Society, and the Scottish Integrated Guidance, something whatnot. They're going to be doing it on the 27th of this month. So there's a big conference somewhere in London, I guess. I don't know where it is. But once they found out what it'll be, the draft has already gone out for feedback, and now they're going to say what it looks like is going to be, pheno. For you to diagnose someone with asthma, you'll need pheno. And one of the things that I found out when I was reading the guidelines for asthma was um, rather than having 8-week sort of like trial of an ICS, the benefit is actually 12 weeks trial of ICS. So the ICB are going to have to pay for everyone's pheno machines, I think. And that's going to be a bit of a contention. But anyway, what can you do?
But then saying that, actually, it was part of the PCN DES as a requirement coming through. That was something that came out a good couple of years ago through NICE. So that's something they should be looking at through funding, and it's out through PCN work streams already. So that's something they should be looking at already on that front.
I hope so.
Just so that it's out there. So again, to follow up from what we actually found on that front, I was going to do a quality improvement project, but I don't think I've got probably enough time to go through it and do it justice in
Sorry, mate.
20
Sorry.
minutes. It's fine. No, I think it was worth doing today and doing it positively and doing it properly, to be honest. And so I think for me, I think we'd rather that we have the engagement, we have more people who want to actually go and do it. So reflecting on today on that front, what are you guys, how do you feel about supporting patients in those clinical areas on that front? And also, Darshan, we're really handy if you can go and jump onto our WhatsApp group if you're already not on it, just so we can share that learning as well.
Yeah, for sure. Like, yeah. I mean, I'll do that in a bit. And I've left my mobile number if that's okay, Jan, just so that.
Absolutely. Well, if you jump on the WhatsApp group, everyone will have it anyway.
Oh yeah, true. Right. Yeah, you're right there. Sorry.
So we've had a few answers come back already saying a little more confident than was 2 hours ago. Amazing. More confident in managing the condition. Great. More confident to carry out COPD reviews. Wasn't really sure about what CAT scores meant before, which is a great learning on that front. More confident and much better understanding. More confident now after this presentation. So you've done a great job, honestly.
Thank you for your blessings.
And I think that's the thing. I think you've got to go and balance of how we do it in practice, because a lot of us will go and do and we'll be like, oh, using your inhaler is this whatever, and we don't want to go back to those medicines use reviews kind of reviews. This is more about a clinical review of up titrating therapy, down titrating therapy, reviewing what's appropriate for that patient. We've got another one, more confident, that it's about asking the right questions and listening to the patients. Spot on. And I think that's what we all strive for, to be honest, is to be able to make sure that we follow through on what's appropriate for those clinicians.
You know,
Um,
one of the things I really enjoyed, which colleagues will enjoy as well if they get the opportunity, one of my partners at the surgery, Douglas Hing, did a health coaching session, and really it changed my mind as a pharmacist. Like before, it was me telling the patient, like I thought I was the purveyor of knowledge and I need to tell them everything. And then after the health coaching session, it actually made me think, actually, hold on, there are two experts here, so really I need to listen to the patient from their aspect of their lived experience, so then I can actually direct them which direction they need to go. So if you can go on to health coaching, I think it's at the Personalized Care Institute, PCI, and one of the doctors for Southwest London, Doug Hing, it provides that education, you know, seasonally, depending on when the Southwest London want to utilize him. But if you do get it, don't delay. Sign up for that straight away.
Perfect. Thank you for that plug, and I'm sure Dr. Hing will be very proud that you've gone and sent him that. The next
Yeah.
question that we have is, so after this session, what are you do you want to implement differently in your practices, and how or what do you need to do going forward to be able to do that? And actually, Darshan, I'll ask you that as well. What would be your take that people could be going and doing quite easily, first and foremost, on that front, in
Well,
terms of what they should be doing?
what I would say is, you can audit COPD patients, or patients who are using oral corticosteroids who have been issued it, or through rescue pack. You can do your searches. You can identify patients who have not had the review yet as part of your QOF, and focus on those guys. You can review individuals who are currently only on blue inhaler but are using it like Thomas the Tank Engine. They might have the opportunity to be escalated. And another thing is using the equipped work streams that we had a couple of years ago from the ICB, individuals who are on open triple therapy, whereby they might be having ICS-LABA plus separate LAMA, like tiotropium. Can we harmonize and rationalize that into a single agent so that it's one inhaler that does all three, and it helps technique, it helps adherence, and it keeps the consistency going? Because if you got a PMDI and a dry powder inhaler, then you're more likely, especially if you've got other things going on, you'll use it properly and you'll have the proper drug deposition. But review these guys. Remember, inhaler technique. We ourselves can't use inhalers properly. How do we expect our patients to use it, right?
I'd agree. I completely agree. I've struggled with using an inhaler for years on that front. So it's really important to be able to go and make sure we go and assess what's appropriate. And those are the similar kind of answers that we're getting on. So again, you don't need to write long answers for these. They're just quick few words at a time. That are these ones. So review tiotropium patients, more opportunistic talking, review the guidelines, audits, a big one that's come through.
Mm.
Guide on rescue packs, review rescue packs, come up twice on that front. Look at coding, rewatch the talk again on that front, which is great.
Yeah.
So really good. Reviews carbazistine use sounds great as well. Use the CAT questionnaire. I think that's a really good one,
Yeah.
because having those a tool and a bit of arsenal behind us, which will help us to support those particular patients, is a big difference, and it makes a difference to your practice, especially when it's an accredited tool that you can use across the board. It
Mm.
makes it easier. I'd also probably say as well, if I've got questions, I'd probably go and just ask them rather than going and just sitting them, because so a lot of us will sit back and be like, actually, it's not, I don't feel comfortable in this area. I feel a bit grey, so I'd let someone else deal with it. Ask those
Mm.
questions, get involved, and upskill yourselves to be able to support the patient, because especially right now,
Mm.
it is that season where people will get ill, and
Yeah,
people
chronic
do
coughs
end
and
up.
stuff. Yeah,
Oh,
so that chronic cough syndrome, like anything greater than 8 weeks, needs to be addressed.
absolutely.
So we need to look at that. And although respiratory has always been the remit, the sort of area for respiratory nurses, sit with your respiratory nurse, see if there's any
Absolutely.
patients you can take over as a pharmacist, because it will expand your scope of practice. It will help you go on to different areas, and then this, as well as what other training you do, can help establish you from a CQC point of view in terms of your competency in providing your prescribing in this area. And it's really it's
Absolutely.
really it's really beneficial to those patients. Like I see patients who are like, I can breathe, and if you can't breathe, you can't live. So to enable someone to breathe really makes a difference, a whole world of difference for them.
Absolutely. So then my final question, as always, is as part of a team, how do you think you can use your knowledge from today's session to enhance the safety of prescribing clinical areas? So Darshan's already given us one. Work in an MDT and get working with your kind of colleagues as well. It may be that actually if you're new to kind of respiratory COPD, you deal with the lower risk ones, and you go and test the waters and build yourself up, and they deal with the more complex patients. So you've got a balance there. So you're upskilling yourself, but at the same time, you're going and putting yourself in an area of comfort to support these patients. We know coughs, colds, flus, COVID, everything is on the rise because of the time of the year that it is. So actually, we want to make sure that these patients are looked after to the best of our ability as well. Because when we look at those patients who are most likely going to be frail, also going to be polypharmacy, also going to go, they're going to be the ones who are coming up on your CQC reviews to say they should be assessed. So it's about making sure we're doing a full assessment for all of those patients. So I've got the first person come back, inform at clinical meeting that it should be LABA-LAMA and not just LAMA alone. Absolutely.
Yes.
Carbocystine can be used PRN and stop when it's not required. Spot on. Absolutely. Discuss this presentation at the next clinical meeting and come up with a plan. Great way forward on that front. Anything else for anyone else? There's a good 28 of you on this talk. So come on, you guys can easily go and talk and write in there what you're doing on that front. And I think it's really important. I think it's really important that we go and look at what the guidance is. Guidance is constantly evolving. That's why we have these sessions, to make sure we get the up-to-date guidance. But actually, there's no point in being on a talk and just sitting here listening to it if you're not going to do anything about it. So it's about, what are you going to do going forward to support these patients on that front? And actually, I'm just thinking out, maybe even to get you in for April to do like the asthma update, because by then things should have been embedded into practice with the new updates to do an asthma kind of thing. So give us a bit of time to get on top of cough, and then we go on top.
Because obviously right now we're still working on the old guidelines. The new guidelines won't come into cough until, like you said, April. So, and I think if you start these things earlier, Jan, if you start, then you're more likely to be a success. Whereas if you're waiting for the last 3 months, you got flus, you got COVIDs, you got RSV, you got, the acute guys coming in with coughs and stuff, and it's difficult to do the long-term management. So you really have to plan out your work from April onwards and start kicking them out, kicking them out, because honestly, it's stressful times, isn't it? And yeah, I get stressed.
Don't get stressed. Breathe.
Breathing. Yeah.
Just
Hava.
breathe.
Okay.
So we've got another one saying, request more allocated time and detail for COPD reviews where they aim to educate patients and follow up regularly to sustain the change. Great idea. Do an audit and update clinical teams. Great. If there's anyone else who wants to put anything into the chat rather than onto Menti, feel free. But I think that we've had a really good session and a really quite powerful session on that front, which I think has been really positively influenced on that front. So thank you so much, Darshan, as ever, for doing it. I think we probably will get you to go and actually do our session potentially in the new financial year, is what I'm going to say, because that's April onwards, where we can go and hopefully get you in for asthma and a bit more on MARD, which will probably help us as well.
Yeah, that'd be awesome.
I was going to do a bit of a session on quality improvement, but we'll try and move that to another time. Because
sorry, man.
No, don't you worry at all. I think it was important to make sure it was done justice today. So we'll move that niche to another day on that front, just so that we're covered. But thank you so much for everyone for participating and getting involved. And hopefully we'll look forward to seeing you all next month again, where we have men's health, and we'll be looking at a bit of a Christmassy quiz, as always, on that front. So please come just for the Christmas quiz, of course. And then we've got our face-to-face in January, I believe, which we've moved because trying to get everyone out of the actual surgeries before Christmas was very, very difficult. So we decided that we were going to do it in itself, going forward in the background on that front. So, but with that, I think we will love you and leave you and call it a day for you guys.
Thank you, Chadley. Thank you, Darshan. Sorry, I've been very quiet today.
No problem at all, man.
Nice to see you, Hala. You okay?
I'm good.
Yeah.
Thanks for this, Darshan. Good to see you.
No problem. See you soon.
See you. Take care.
Bye.
Hala, do you want to stay on?
Yes.
Oh dear. You're right, love.
Yeah, just busy from one thing to another, and the GPs can hear that you're in a meeting and they still knock and they would still want their answers.
I literally just had that, don't worry. So I'm
Yeah.
like, that's fine. It's all good.
Yeah.
So it's all good.
How was the session? Sorry, I missed like half an hour of it.
No, it's fine. It was good.